Hi everyone, Dr. Minasre here. After exploring the first two parts of this series, the fundamentals of lung ultrasound and diagnosis of pulmonary disease, today we move to the third part, focus on clinical protocols and their practical applications in critical care. Our goal is to bridge theory and clinical practice to learn rapid, reproducible, and standardized protocols directly at the patient's bedside. First, the Blue Protocol, which stands for Bedside Lung Ultrasound in Emergency, was described by Daniel Lichtenstein. It allows clinicians to determine the cause of acute dyspnea within minutes based on specific ultrasound patterns observed in standardized chest zones, anterior, lateral, and posterior lateral areas. Each echographic profile or pattern points toward a main cause of respiratory failure. Pattern A: predominant A lines with normal pleural sliding, dry lung, indicating preserved aeration. Typical etiologies: COPD, asthma, or acute bronchitis. The pattern B is multiple diffuse bilateral B lines, interstitial syndrome suggesting cardiogenic pulmonary edema. Then we have the pattern C, subpleural consolidations with air bronchograms. This non-aerated lung is suggestive of pneumonia. Then we have the pattern AB, asymmetry between sides, A profile on one side, B or C on the other. This is seen in unilateral pneumonia. Then the pattern N with normal A lines and pleural sliding bilaterally. If we have this pattern in dyspneic patient, we should consider extrapulmonary cause, typically pulmonary embolism. In this case, perform venous ultrasound to look for deep vein thrombosis. The other pattern is A prime, absence of pleural sliding with A lines. This is pneumothorax. Use the M mode to look for the barcode sign, replacing the normal C-sharp sign. The second protocol is the Falls protocol, also developed by Dr. Lichtenstein. It's designed to identify the cause of circulatory shock and to guide fluid administration using ultrasound findings. So FALS stands for Fluid Administration Limited by Lung Sonography. It is a stepwise sequential protocol exploring each potential cause of shock. So step 1, pericardial assessment to rule out cardiac tamponade. Pericardial effusion with chamber collapse or paradoxical septal motion. Step 2, RV evaluation to rule out massive pulmonary embolism with dilated RV, paradoxical septal motion, or here McConnell sign. 3, lung assessment for pneumothorax to exclude tension pneumothorax using B and M modes to check pleural sliding. At this stage, we rule out obstructive shock by assessing the heart and the lung for tamponade, PE, and pneumothorax. Then we can move to the fourth step with looking for the B line or the lung profile. The absence of bilateral B lines make the cardiogenic shock unlikely. And here we can initiate fluid therapy. Since there is no congestion or obstruction, then we will monitor the response to fluids. If an improvement without new B-lines, it's likely to be hypovolemic shock. If persistent hypotension without congestion, we consider distributive shock. If new B-lines appear, fluid overload or evolving septic distributive shock, so fluids should be stopped. Finally, we reach the ultimate step, the integrated cardiopulmonary assessment, as recommended by major societies of critical care. This comprehensive bedside strategy combines clinical examination, lung ultrasound, and focused cardiac ultrasound. So to use this ultrasound-based protocol for diagnosis in patients with respiratory distress, here is the approach. First, we'll start with the clinical context and patient's history. Then you perform a pleural ultrasound. The goal here is to rule out a gas or liquid collection, meaning pneumothorax or pleural effusion that could be causing the distress. After that, we move on to examine the lung parenchyma, and we'll have three situations. If we see B lines on one side, it's probably pneumonia. If we have bilateral B lines, this indicates interstitial syndrome. The critical next step is to differentiate the cause. Is it due to cardiogenic pulmonary edema or non-cardiogenic edema from lung injury like ARDS? This is where you immediately integrate echocardiography to assess cardiac function and filling pressures. The third situation, if we find consolidation, this is probably pneumonia, and you'd look for dynamic air bronchogram to confirm. Now, if the lung ultrasound is normal in a patient who's in respiratory distress, you need to look for an extrapulmonary cause. You'd investigate a cardiac origin like massive PE or tamponade. You'll do vascular ultrasound to look for DVT. Finally, if all of those signs are absent, you suspect a bronchial pathology like COPD or asthma exacerbation. This integrated approach is used daily in ICU practice for ARDS monitoring, daily lung ultrasound score, for weaning assessment, assessing the diaphragm excursion and the thickening fraction, in the PEEP titration and evaluation of lung recruitment hemodynamics, and also for fluid management by integrating findings from the lungs, heart, and IVC. So in conclusion, we should say that the lung ultrasound offers a new perspective, combining the speed of imaging and the depth of clinical resonance at the bedside of critically ill patients. Thank you all for your attention.